Welcome back for School of Airway. Another perspective, bird's eye view, I guess, perspective of using the Pentax AWS. This model is the 100, but it's basically similar to the 200. There's a case that's provided in. Open it up. Alright, so to know if it's working, first know if the batteries are working, which is our 2 AA batteries. How you know where they are? There's a locking mechanism most of these devices have. You open, slide down, 2 AA batteries, lock it, put it down, regular screen, that's what I should be cleaning, keeping clean, turn on, green light, good, red, bad. Right, when you see the crosshairs, crosshatchings, okay? So now I need to proceed, not putting the ET tube on the blade. I need to engage the blade, okay? So how am I going to do that, okay? How am I going to do that? I remind myself, the screen that I'm reviewing towards me, the blade tip away. Now don't push hard, push down and let it lock. Again, push down, let it lock, and let go. Now that's one locking mechanism. Then I turn it to the left, another locking mechanism. Now it's ready for use. Okay? So, alright. So now if I want to engage and put the tube on, I did what we talked about last time. And of course this is partially not a perfect ET tube. So we'll place it now. For a tube that's not torn, I will actually guide it between the 2 anchors that are provided here. Push down to make sure it doesn't slip out. This tube has already been lubricated with KY or water soluble solution material lubrication. Fit my syringe on already. No need for a stylet because it's a channel device. Okay, so are we ready? I hope so. Hopefully the patient's been pre-oxygenated. Hopefully the patient's been positioned in a ramp position, simple position. And I'm ready for intubation. Okay, so how do I insert this? Either do a jaw push or scissors and opening the mouth. Okay, you have to distract the mouth somehow. Once you open the mouth, I usually enter. I enter with the DL blade, not midline, so I don't want to cause any ruckus with the chest. The man boobs, breasts, or the female. I don't want a challenge, a gorilla challenge, chest pumping. So I enter through the side. As I enter, I slowly rotate. All right. Rotate deeper and go to midline. So almost always people are going to be too deep. Okay. So then I try to pull up, not backwards, hitting the face. If you do this, you're hitting the face and hitting the teeth. That's the wrong way of intubating. What you need to do is pull respective to the floor, pull upward, and then turn your wrists. Some of you guys develop acute carpal tunnel syndrome here. I see the target sign. I see where my tube should go, and I push it through there. Okay? Once I do that, I disengage the ET tube by forcing down my thumb smoothly, not in a jerking maneuver, and pull out. Those who are at the head of the bed will see how I slowly, as I entered, in a rotating deep and put the blade in, and with the Pentax, I will disengage it the same way, smoothly. Everyone who saw me intubate through the cords. Right. You can put your capnometry on, you can put your end-tidal CO2 on, it's in. Okay? Alright, so this device is not that complicated. You almost always wind up with a Miller view because the blade is a little longer than the air track. But guess what? That's not wrong. It's being used correctly. If it does wind up being used as a Miller view, it's not wrong either. Sometimes maybe the orifice of the patient is that deep, that cavernous, and you may have to use it that way. Okay? Okay. welcome. And hopefully I'll come back. You'll be back again for more videos by Dr. Torres and the School of Airway. Bye.